So let's talk about hypertension. Hypertension is a silent killer. It is major. It is one of the leading causes of major health issues in our country and actually in our world. So let's get started with this. There's primary hypertension and secondary hypertension. So primary hypertension is genetic or environmental causes, and we'll go a little bit further into this here in just a minute. Secondary hypertension is secondary to other conditions. So there's different things out there that have created you to have hypertension. Genetic, you get it from your parents, whatever, grandparents, great grandparents, you get it through that genetic pull. And environmental is you've been exposed to something that's caused you to have in the outside world to have hypertension. But the multiple other conditions, that's where we've got other disease processes that are creating or having the body is having to work harder and it creates you to have hypertension. So, pathophysiology on this, we can have smaller diameter of blood vessels. And if you think about it this way, if I am pushing blood through my blood vessels, if I have smaller vessels, I have to push harder to get the same amount or the blood flow to go through than if I have larger vessels. So if I have something that is teeny tiny. It's like a straw. Have you ever drank a drink through one of those little stirrers that's a straw that you stir with? They're teeny, right? It takes a lot of strength to pull that fluid up through that stir into your mouth. Unlike if you have a regular size straw, and then that in comparison to if you have one of those oversized straws. It's so much easier to drink so much more through the big straws compared to a regular size straw and then in comparison to a stirrer. I hope that it helps a little bit. Increase in volume or viscosity of fluid in the blood. If we become volume overloaded, remember when we talked about volume, then we can have an increase in blood pressure, right? Viscosity, just remember, is thickness. Is the blood thicker? Does it need more volume? If I'm pushing something that's thicker, usually it's heavier, right? It's harder to move. Let's look at milkshakes, right? That's an increased viscosity of something we're drinking. And because of that, that thickness, it takes that much more pressure to move it through the straw than if it's thinner. Stress stimulating the sympathetic nervous system and excess renin secreted by the kidneys. So, different things can happen in the body. If we have renal dysfunction or renal disease, we're going to have hypertension because it's going to have excess renin secreted. And that renin, angiotensin, the whole little thing that you learned back in anatomy, that is starting to play into this. I don't want to get too deep into it because this is an introduction to hypertension, but we will go even further in depth as we go through nursing school. So, hypertension, it literally means high blood pressure. Hyper, right? It's high. Yes, we're hyper, we're all over the place. And tension is pressure. So high blood pressure is hypertension. Opposite is hypotension, and hypo is low. And that's how you can kind of remember it. Hypertension and hypotension. Systolic blood pressure is the first number that you see when you're taking a blood pressure. So it is the pressure that the blood exerts on the vessels when the heart pumps. It's the squeeze. So what happens is you put your blood pressure cuff on your patient, you tighten down your sphygmometer, you pump it up above the heart so there's no sound, and then you slowly release. The first bump, and that's what I call that when you hear it goes bump, right? When you're listening to the blood pressure, that is your systolic blood pressure. Systolic blood pressure is the squeeze of the heart. It's the pump of the heart. It's systole. It's when the heart is pumping and squeezing. Diastolic pressure is the pressure that the blood exerts on the vessels when the heart is resting or relaxing, decompressing. It's your bottom number. So the top number, you've got the squeeze, and the bottom number, you have the resting. That's the diastolic blood pressure. That's that last bump that you hear. So it's bump, dump, 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 right? That is your resting or relaxation. I always think diastolic blood pressure, resting, systolic blood pressure, squeeze. So you could combine the S's to make you to remember that. The next thing on this, and I don't want you to overthink this, is stroke volume. Stroke volume, and you'll see this later as we go through nursing school, but I want to introduce this one little term for you right now. Stroke volume is the amount of blood the left ventricle pumps out. So this, when you hear stroke volume, they've got a decrease in stroke volume. That's telling you that the left ventricle is not pumping efficiently. We're not pumping enough blood out. If stroke volume is normal, we've got a great left ventricle. It's doing what it needs to do. So just kind of know stroke volume in the definition. It's the amount of blood that the left ventricle pumps out. That's all you need to know right now. So let's take a look at this and think about it for a minute. If I have a narrow vessel, it creates a higher pressure. It creates more pressure. So when I'm pushing blood through that vessel, my blood pressure will increase. It's like looking at a small little doorway and you're trying to fit yourself through it. And it's so small, but you're pushing your body through. And how much force and pressure does it take to push yourself through that doorway? A lot. When you do that, it's going to increase your blood pressure according to blood flowing through something more narrow, just like by pushing your body through the doorway. If I've got a big doorway, it's double doors and it's wide open, I can walk through it without any issue. I can go through it easily, quickly, and there's no issues. I have a lower blood pressure. So if I have vessels that are dilated or open or bigger, it's easier to push the blood flow through, right? Just like the straw analogy, easier to get through. If I have something that's smaller or more narrow, it takes more pressure and more work and it makes the pressure build and I have a higher blood pressure. Where this is important to understand or why is because certain things happen with congestive heart failure, with other disease processes, with acute MIs, but also medications. And that's something that my students right now, and I'm sure a lot of you out there are doing, is you're giving different medicines. So if you see a medicine that is a vasoconstrictor, that means it's constricting or making the vessel more narrow. It's clamping it down. It's creating a pressure that is going to make it harder to get through, the blood to push through, and it's going to increase the blood pressure. There are times we need to increase the blood pressure. And then there's times we need to decrease the blood pressure, and we'll give the patients medications that vasodilate. They're going to open the vessel as much as it possibly can so that blood can flow through easily without creating a pressure, and it's going to lower the blood pressure for the patient. So heart rate will go higher when the blood pressure is higher, and heart rate will go lower if the blood pressure is lower. So the HR on this slide is heart rate. So if I have a high blood pressure, I normally will have a higher heart rate. If I have a lower blood pressure, I'm going to have a lower heart rate. Why is that important to understand? Because the heart is what is creating the blood pressure. And if I'm working harder because I'm having to push harder through, I'm going to pump harder and faster trying to make this happen. It forces the heart to work harder. If I lower my blood pressure, it lowers the heart rate and it helps offload workload. I hope that helps. Just think about it, mull that over and process. So, blood pressure, hypertension, once again, high blood pressure. Hypertension is currently one of the most common disease states. And that is so sad because it's something that can be prevented or intervention can take place and controlled. And so, why? And we'll talk about that here in a minute. Also, just so you know, hypertension is a major risk factor for coronary artery disease and cardiovascular disease. So, for some a disease process, hypertension, something we can control, it's sad that we don't control it because what's going to happen in time, it's going to reap havoc to our arteries, our veins, and our heart. And it's going to cause us to have disease processes that take place that we can't reverse. We can intervene to the best of our ability, but a lot of times when you have a history of these or you have these issues or problems, it's going to then just escalate and escalate and escalate until you die. I hate to say it that way and be a Debbie Downer, but that's the truth. So control is the ticket and prevention is even better. So, classification of blood pressures. Hypertension can also be defined by its cause. So, we have unknown causes. It can be essential, called essential hypertension, idiopathic hypertension, or primary hypertension. So, sometimes you'll read that in doctor's notes. So, understanding that term means it's an unknown cause is important. 90% of the cases of hypertension are considered primary or essential or idiopathic hypertension. That's a lot. But what are factors that can cause this or can be a part of this? And it could be obesity, alcoholism, high salt intake, but usually it's something that happens over a period of time, a long period of time. That aging process is where we see this going on. Sedentary lifestyles, stress, and maybe, poor dietary habits where you're not eating what you should. Secondary hypertension would be 10% of the cases. And that would be like after having an acute MI, and now all of a sudden you have high blood pressure because your vessels have disease. You have coronary artery disease and you have blockages, and the muscle's not functioning properly anymore because you've had that heart attack. That's a secondary hypertension. So understanding the primary, and that's the majority of cases. So you can do things though to help prevent or slow that process from happening. Secondary hypertension is 10% of the cases. I think it's kind of interesting that whole note there, that's what we see. So, hypertension defined. Let's talk about this. We just talked about that this aging process can take place. And in that aging slow process, we start to develop hypertension kind of almost naturally, a little bit more. We'll become a little more hypertensive. The aging process, vascular system starts to get a little harder. It's not as pliable. Our heart muscle is not working as efficiently as we were when we were 20 years old, for all you 20-year-olds out there. But what we say is that any blood pressure, systolic greater than 150, diastolic greater than 90, is considered hypertensive for someone 60 years or older. So when you're in clinical and you have a patient and they are older than 60 years old and you have a systolic blood pressure of 142, 146, 148, 138, and it's bouncing around in those numbers, they are not considered hypertensive. Or they could have a blood pressure of, let's say, 130 systolic and 110 diastolic. That would be really bad. But if that's the case, they're considered hypertensive. So anybody older than 60, those numbers are what pertain to hypertension. And then if you drop down to the next point, anybody younger than 60 but has chronic kidney disease, chronic, and diabetes and/or diabetes, then they have blood pressures greater than 140 and greater than 90 diastolic to be considered hypertensive. You need to put that in your notes. You need to highlight that, and you need to start to apply that in your critical thinking in the clinical setting. So let's talk about it. Signs and symptoms of hypertension: headache, dizziness, blurred vision, blackouts, irritability, angina, dyspnea, or fatigue. If you don't know some of those words, you need to go look them up. They're terms that you need to know in the medical world. The goals in treatment: let's reduce that blood pressure. If we can get their blood pressure down and keep it at a reasonable level, then we can stop the signs and symptoms or decrease them at least, and also hopefully preserve the heart and the vascular system and the kidneys and all that are involved. Long-term control is to decrease the risk of stroke, heart attack, loss of vision, and kidney disease. Those are all biggies, guys. So that's why it's so, so important that we do something about high blood pressure. Smoking cessation, if they'll quit smoking. Nicotine is not our friend. Nicotine, even if it's absorbed through other forms of tobacco product, we have that. If someone dips or chews, we're in the South here, so we have that a lot. And so that is another way to get nicotine into the system. Um, Also, talking about nicotine, let's talk about drinking Cokes and coffees and teas, high caffeine use, um, those energy drinks that have double, the amount of caffeine to get you awake. They're vasoconstrictors. They are actually constricting the vessels, making your blood pressure go up, making your heart rate go up. That's why you feel more awake, because that's what's going on in your body. And by doing that, you kind of go, oh, and it gives you that natural kind of high with caffeine based on what it's doing to the body. Sodium restriction, and we'll talk about that a little further when we talk about the diet. Alcohol restriction, alcohol is also not our friend. Exercise, let's start to exercise, eat a low fat diet, and control our stress. If we do these things, we can decrease our blood pressure. So when we're talking to our patients, or when you're gathering data, you're going to want to look at the history. Do they smoke? Do they use a nicotine product? Do they drink? You want to ask them, do you drink caffeinated beverages? Do you drink coffee? Do you drink tea? Do you drink Cokes, Mountain Dew, all those that are high in caffeine? Do you do energy drinks? And that's one of the biggest right now, because we have seen things happen. You've seen younger people who've, like football players, these young high school football players, they'll drink 3 or 4 Red Bulls and then go out on the field to play. They've had heart attacks. They've cardiac arrested on the field, because then we're under stress and we're running and we're pushing our heart even harder and faster. And they cardiac arrest. And so it's become a big issue with those. And that's something we need to think about, because we have easy access to. They taste great. I won't lie. I've had them myself before. Monster drinks, those things, they're yummy and they do wake you up. They make you feel good, but they're reaping havoc to the body. Just remember that. And then, of course, antihypertensive therapy. That's our medications. That's where we give things to bring the blood pressure down. And sometimes it takes that to make it happen. So when we're looking at primary hypertension, that's the one we just talked about, that's 90% of the folks out there. There are non-modifiable risk factors. This is something you need to understand and know, because you're going to be given scenarios, you're going to be put in clinical situations, and you need to understand. One is age. We talked about that. We can't control that. As we age, our blood pressure goes up normally, naturally. Gender, males are more hypertensive than females. Can't control that. Ethnicity or race, we see that the Black community, African Americans, they are at higher risk than, say, Caucasians. But I will tell you, as life moves forward and we all have different, or we're dealing with more of a more diverse community, and we're all getting our food from the same place, we're eating, we're doing the same things, we have the sedentary lifestyles. It's evening out a little more, but I will tell you that it is still, Black males are the highest at risk for hypertension than any other individual out there. And so that's very important. So what does that say to me? It says to me we need to be out there targeting that demographic so that we can teach them, help them, and hopefully prevent them from having the heart attacks, the strokes, and dying at a young age from this issue and problem that can be helped if possible. And then, of course, family history. If mom and dad have hypertension, grandma and grandpa had hypertension, great grandma and grandpa had hypertension, all the aunts and uncles have hypertension. And then, of course, you most likely will have hypertension if you don't already, and your siblings will too. Now, it doesn't necessarily mean so, but family history does play a role in this, and that's the genetic aspect of it. But those are things we can't change. Those are just things that roll out. But the things we can modify are drinking, alcohol's up there, cigarette smoking, talking about the nicotine, diabetes. Let's control the diabetes. Let's prevent diabetes. They go hand in hand, diabetes and hypertension. So we have all of this issue with the heart and the vessels, and you just learned about diabetes, or you're going to learn further or more about diabetes. But in metabolism, when we're talking about that, sweet, sugary, sticky blood is not our friend. It damages blood vessels, it damages the heart, it damages the kidneys if not controlled. And with that, it'll increase blood pressure, right? There you go. There's your chronic kidney disease. And it's come on by this big, thick, sugary blood that's uncontrolled. How do we control diabetes? Diet. Type 2 diabetes is modifiable by diet and exercise, period. Obesity. I'm right in there with everybody else in this world that's obese. I'm right there on the number charts when you look at it. I admit it. I can raise my hand. I could go to therapy for this. I am considered that also, but we have to control it. And how do we do that? It's diet and exercise once again with obesity. We are throwing meds in our country at this like there's no tomorrow. But what we need to be looking at and throwing money at is our food. Our food is highly processed. It is full of everything. I want you, the next time you go to the grocery store, I had you look for salt. I want you to now start to go through, and I want you to look at sugar and what's processed, what's in the food you're eating. You're going to be absolutely amazed. You can pick up salad dressing, look back, sugar. You can pick up ketchup, one of the biggest, sugar. Our condiments are full of stuff, salt and sugars. We need to start to really look at what we eat, and that's going to help with diabetes. It's going to help with obesity. And we know that obesity goes along with type 2 diabetes. Here we go. Elevated serum lipids, that's our cholesterols. Excess dietary sodium, we need to decrease the salt in our diets. The elevated serum lipids, that's the fatty in there. That's what causes blockages and stuff that can cause a lot of issue. And of course, lower socioeconomic status. We are all affected by the grocery prices that we're paying right now for food. Truth is when I was raising my two boys, it was a lot easier back then. But when I did, they ate me out of house and home. So I was the single mom on a nursing salary. And I'm telling you, what did we supplement with? Peanut butter and jelly sandwiches, because they would eat dinner, and immediately as that last bite went in, they'd say, "What are we going to eat? What can we have for a snack or dessert? What, I'm still hungry. What is there?" And they've already eaten like first and second helping. Now they were swimmers in high school, so they would go swim, so they burned a lot of energy. So they were starving. You know what I mean? They were ready. They could probably eat a cow walking across a pasture if I'd let them. But the truth is when you're dealing with money, it is easier to eat cheaper, higher processed foods for less amount of money than it is to eat whole foods, which are fresh meats and fruits and vegetables. I watched a documentary, guys, on this. It was really interesting. It was a family. The parents were migrant workers. They did make a lot of money. They had two little girls. The little girls were in elementary school. But they were both obese. The two little girls were obese. And so the look is what are they eating? And the mother said, she didn't speak English, but the mother said, it is cheaper for me to go through a drive-through of like a McDonald's or a fast food restaurant and feed them off the value menu. So for $10, she could give them, for $5, she could give them each two hamburgers and two French fries for that. And what she did is she took $10 and she would get them two hamburgers each to fill them up, and that she could feed the family on this for about $10. But that food was so high in fat, salt, and processed mess that they could not, and they didn't have a chance. They weren't getting that fresh food and stuff that they needed. And so it was interesting because the documentary then took them into the grocery store and taught them to grocery shop and looked at choices they could make. And that's another thing, is teaching people what they can eat and how to work and get the foods that they need. So it's something to think about. Also, too, with lower socioeconomic status, is you don't go to the doctor as much. You're not there at the doctor. You don't have the insurance, or you don't have the money to go pay the doctor to be seen. So you're not being observed or watched on your vital signs. So you can have high blood pressure. It goes on for a long period of time. And then all of a sudden you start to have these issues, kidney issues, renal dysfunction, cardiac issues, and it all stems back to you probably have had hypertension for a very long period of time and it's not been controlled or watched. Now, I'm not going to go into a lot of this in this semester for my students. This comes next semester. But hypertensive crisis, this is what can happen. So you can have a hypertensive emergency. This is a life-threatening situation. It's when the blood pressure rises higher than 180 over 120. There is an indication of target organ damage because of this. If you get too high, you can have organ damage. You can have severe headache, blurred vision, seizures, nausea, and change in level of consciousness. They can go unconscious on you. So this happens in a hypertensive emergency. Emergency, think 911, right? They're going to die if we don't fix this. Hypertensive urgency occurs when the blood pressure rises to 180 and diastolic 110, but there's no signs or symptoms of target organ damage. This is a more common occurrence. The patient is observed in the emergency department and treated with some oral medications to lower the blood pressures, and then they're directed to follow up with their provider. So they can come in and have a hypertensive urgency, and that's what's going on in this bottom part, this little second section that you see. But the top piece is the emergency. Anything above 180 and 120, there's damage being done to the organs, and there needs to be intervention immediately, or we're going to see bad things happen. So this is what happens with complication of uncontrolled hypertension. Hypertension can cause damage to the arteries that makes them less elastic. They become non-compliant. So as they become less elastic, what happens? It creates more pressure for blood to go through, right? So all it does is creates more hypertension, and then we have issue. But the damage is done to those arteries. They're not going to work efficiently. It's going to increase our workload to the heart. That muscle is going to work and work and work and work until it can't work anymore. And what happens is we can have myocardial infarction. We can have left ventricular hypertrophy. This is where we get congestive heart failure, or we have an oversized, just thick heart that doesn't function. Either one of those is bad. It's not something that we want. Small vessel damage can cause TIAs and stroke to the brain. That's what happened, is it will cause damage to those small vessels when we have hypertension, and that's why people stroke. Hypertension can cause damage to small vessels in the kidneys, and that's what causes us to go into kidney or renal failure. So usually with people with uncontrolled hypertension, we will see them have strokes, TIAs. We'll see them have cardiovascular issues, go into congestive heart failure, and have kidney or renal failure. So that's why it's so important that we control it. Hypertension damages also the arteries of the eye, causing formation or occurrence of a hemorrhage in the eye or a blockage. And because of that, it can cause them to go blind. So we do not want any of these things to happen. So it's so, so important that we control hypertension. So we have a nurse that's promoting which lifestyle modifications for a 39-year-old patient who is diagnosed with pre-hypertension. Select all that apply. Just read that question and see what you can answer. I'll give you just a few seconds. So let's take a look at these answers. Smoking cessation, you can tell them to not smoke, do not use nicotine products, quit smoking. We can do things to help them with that, right? There's medicines out there to help with that. There's also nicotine patches if we need to, and they just keep lowering the little amounts of nicotine. Restrict sodium intake to 5,000 milligrams a day. We're going to talk about diet here in a second, but that amount is way too high. They need to restrict it a lot less than that. Aerobic exercises, get out there and walk, move. What are we doing? We're causing circulation to move throughout without any issues. We're strengthening the cardiopulmonary part with aerobic exercises of the heart. That is heart and lungs. We need those to function correctly to perfuse and live. Alcohol intake of 3 servings per day is incorrect because you should tell them no alcohol. We're not going to drink. Alcohol is a bad thing for our for hypertension. And a low fat diet. We do want to get off of onto a low fat diet. Actually, there's a lot of research being done right now, and I want to say this. You have to remember that when we're looking at information, this has been gathered from years prior, that's put into a book. It takes all this time frame. So today, as we're looking, there are different things we can look at. But if you have if you exercise and eat right and do the things that you should do, take the supplements you need, don't smoke, don't drink, all of those things. When we're looking at the diet piece, you can eat good fats. And that is important to understand. That's where we're starting to see where keto, paleo, those diets are actually really healthy for you. But you've got to be healthy on the other end. That's where people make the mistake and don't understand. If you're 350 pounds and you're 5 foot even and you're eating all the bacon out of the refrigerator because you're eating, a keto diet to try to lose your weight, you're not eating healthy fats, and you're also not and you're sitting playing your game system or watching movies all day on Netflix. You are not doing what needs to be done, as you're partaking in beer every weekend because you're watching football or whatever on TV. Point to the story is different things, but we're starting to prove if you do the healthy things, you can actually eat the healthy fats and increase those and get healthier with how the body uses sugar efficiently and uses energy efficiently. We can debate this and talk about it. I'm very pro those things. And research is now proving that it is better for us. Eating low fat diet yogurt and stuff like that, not too healthy for you. It's full of sugar. So you got to look at the whole picture. And sometimes that's hard for folks. And that's why, as nurses, understanding things is so important so that we can help guide them because it's something they don't know. So DASH diet is the diet of choice. It's a diet that approaches to stop hypertension. It's a heart healthy diet. So we give it DASH diet to people that have cardiac issues, help lowers blood pressure. It's important to watch the amount of salt or sodium in your diet. That's what the DASH is. We're getting that salt. I always think DASH. And I think DASH, sometimes you can think of the sodium supplement, but don't forget when we talked about the sodium substitute that we can use, the DASH stuff that we can sprinkle on our food, that is full of what? But potassium. So we have to be careful if we've got renal disease. We can't just be dashing and salting everything up. We've got to be very careful with what we do and what we use. Eating foods with sodium, low sodium, or a lot of sodium can lead to high blood pressure and other health conditions. Your total amount of sodium per day should be no more than 1,500 milligrams to 300 milligrams. Now, I'm going to say this to my students. If your book or your videos say a different number, go with the number they give you. But I can tell you the research and all the numbers that are out there in the world with American Heart and those things, it's 1500 milligrams is the very low end of it, and 2300 milligrams is the very high end of it if we're using a DASH diet. I think someone told me once that 3000 milligrams is, reasonable. But point to the story, numbers can be altered and changed just by a fuzz here and there based on the books or the information that are given. For my students, use what's in your ATI, but I can tell you that I've done and looked at American Heart, looked at some other things. 1500 milligrams is the low end of it, 2300 milligrams is the high in it. And so and it's usually a low fat diet, low sodium diet, usually eating more healthy proteins, uh, looking at your fruits and vegetables. They do push grains on this. I'm not a big grain person in the world. I think grains are not always the best unless you eat really good grains for you. You would think I'm a big healthy diet person, and really I just love robin eggs, those little malted milk ball candy things. I mean, I've taken myself off sugar and I've been off sugar almost 2 weeks now, but it's hard. I won't lie. It's hard. But start to read your own food. Do your own research on what you're intaking. I think it's the best way to kind of understand. I used to do cardiac rehab on the side. So one of my little side jobs I would do through the hospital. And I would usually pick up during holidays. And I'm just going to tell you, a can of cream of mushroom soup, Campbell's cream of mushroom soup, any cream of mushroom soup, store brand, whatever, has enough sodium for an individual for pretty much, you know, days, weeks for them. If you're doing 1500 milligrams, you could probably, that's enough for like 4 days or whatever. Look at the numbers on the back of those. It's a high sodium diet. So what do? We make green bean casserole, one of my favorites, right? Green beans, cream of mushroom soup, put the onions on top, bake it. It's so yummy. How many cans of cream of mushroom soup do you put in that pan of green bean casserole? One, two. A lot of people put 2 to 3 cans. Add that up. Then you put a pile of that on your plate. Well, it's green. I had a patient say to me, well, it's green. And I said, it's green and laden with soup, which is high in sodium. You got to watch that. Elderly people, they like soup. It's very soothing to their stomach. It's very easy for them to prepare. You open up a can, put it in a bowl with a little water and some of it, and stick it in the microwave or put it on top of the stove. And they have a dinner with a few crackers, add more salt to that. Do you see where I'm going with this? So it's so, so important that we help them understand. I had a little gentleman and he said, I've been watching my salt. I promise you, I've been watching my salt. And I said, well, I believe you. And I did believe him, and he had been. But what he didn't understand is that the soup he decided to eat every night, because that's what he thought was healthier, was full of sodium. And he didn't understand the breakdown. You can say that, and then you look at it, they could have it in grams. 0.05 grams, is all you can consume, right? If you had that, then we know that's just 50, right, micrograms, or milligrams. If it was 0.05 milligrams, it would be 50 micrograms. If it's grams, into milligrams, and they don't know the conversions. They don't understand it. They also don't understand that that's our main source of preservative of all of our food on shelf life. So salt or some form of sodium, they'll have different names also. So it's so important that we help teach our patients, understand, and work towards creating a diet and health regimen that will help either prevent hypertension or control hypertension. I hope this video helps.